Thanks a lot for all the veterans who have joined here on World Heart Day 2020. Today, we will be discussing a very important topic, COVID-19 management in cardiac care during COVID 19. It's very pertinent that we discuss this topic today and particularly on World Heart Day. I would like to welcome all the panelists Dr. K.M. Cherian, cardiac surgeon, Frontier Lifeline Hospital. Thanks a lot, sir, for taking time and coming in. And Dr. Balbir Singh, Chairman, Cardiac Science, Max Healthcare. And Dr. COVID-19 management and with cardiovascular disease. But the first and observation always remains very helpful. So I really want to, ask the panelist here. First of all, what have been the experience you have seen in the initial stages of lockdown when the pandemic had hit us? How you have seen how it has got better now, the pattern, if you could just tell me, in regards with dealing with this pandemic with the cardiac patients. Dr. Kane Chirin, your thoughts, please. Please unmute yourself. So you have to unmute yourself. Unmute yourselves.
It is not the question of muting, it is my voice. Can you hear? No?
Yes, I can hear you. Please go on.
Okay. No, I'm saying that I should not be sitting here because I have no idea about this. The only experience I have is regarding my wife. Unfortunately, she died last month from COVID. So that is what I was telling Ganesh and OP that the management of COVID patients is little different. The reason is this is a new disease for all of us. So I was just saying that 44 years I have completed in India as a cardiac surgeon. Now, how many people do we have with experience in treating COVID patients and especially in cardiac surgery? Very, very few. Everybody avoids. The reason is their own safety. Even, why I'm taking my wife as an example is I could not see her the last moment. They won't allow. You have to have the PP kit, that, this, all sorts of hyperbaric. It is very difficult. So this is a new disease about which we don't have much idea to talk about. I mean, especially me. From the surgical side, I'm sure that may be the same experience with Ganesh also, or OP also. So it's really not a surgical problem. But it is a surgical problem because people try to avoid surgery. Just now, why I got little late is we had a patient, 57-year-old lady, who had an angiogram done, for whom we had to clear naturally COVID test negative, angiogram done. She has got 95% left main. So what are you going to do? And a very, very small right, severe angina. So she needs surgery. Luckily, she is COVID negative. But still, there are a lot of things which we have to look after. So, in general, if we have got 4 theatres, 3 theatres, or 5 theatres, we have got 5 theatres. We operate only in one theatre. Other theatres are kept empty. We don't operate. So, planning the strategy, explaining to the patients, the relatives, the risk of surgery. The risk of surgery in the sense, it is mainly one.
How the fear factor you can mention how it's been if so.
How, how
So you've completed your thoughts, sir, Dr.
no,
Cherry?
I'm just saying that if you have got 5 theatres,
Yeah.
you are using only one theatre, all the other theatres are empty, kept empty.
Mm,
And putting on all these things and trying to operate is a big, big, big headache.
mm.
And then you have to look after a big team. You have to take the protection in all what is possible for your teammates. 7 people, 8 people. So that is totally different from dealing with a cardiology. So it is different, very different.
Okay.
That's all.
Okay. Yeah, if I go back to Dr. Dalvi Singh ji, if you can just tell us about how have you seen the last 6 months? How has been the pattern of this pandemic, and when you're treating the patients, what kind of experiences you had in the initial stages, and how better it has become right now, right from the fear of patients to coming into an hospital, or the cardio different syndromes you deal with in the cardiac problems you deal with. If you can just give us a brief on that. So you are on mute.
Yeah. So I guess we have been through very tough time, and we are still going in a very tough phase. Let's go down to the lockdown period. I can personally quote many examples where the patients died because of lack of medicines or lack of healthcare. There are patients who were in remoter areas. They just couldn't reach any health facility. Their close by nursing homes were closed. They used to call us. We used to say, please go to some hospital as close as you can. And they would say that it's closed. We can't do anything. They would try to come to us and never reached because there were barriers. There was no transport. I came across one patient today who couldn't get the medicines and had a heart attack because he just couldn't get it. He was on a stent and could not get the blood thinning agents. It was a miserable time for heart patients during this lockdown. We were saying that we are stopping COVID deaths, but we were losing more cardiac patients who were dying. So it was a very miserable story that happened that time. There was so much fear amongst people that they don't want to go to hospital even if they were having chest pain during that time. So the good change that has happened now is the patients are less fearful now. They are trying to visit hospitals. They understand that if they don't go with non-COVID illness, they may die from that rather than to risk a COVID illness. But what about those who are 75 plus? They find it so difficult because if they get COVID, the chances of a problem are high. Then our cardiac patients also we tell them that please don't come unless you have a problem. So it is kind of a very difficult situation from both ends that if we try to avoid the patients, they may end up in a mess. If we call them, what if they get exposed? But now, as the time passes, one good thing has happened with COVID illness is that less patients are on ventilators, less patients are dying. There is more recovery, possibly because of better drugs available, possibly because of some studies having shown some of the drugs having worked. In our institute, plasma worked well. So remdesivir worked well. So I guess the recovery rate with that has gone up, and maybe some immunity in the community has reduced the spread. But for the cardiac patients, it's been a really very unfortunate time, unprecedented. We don't have any experience to handle these patients. Our physicians would shy off if somebody had chest pain and had ECG changes and has COVID positive. Most of us had difficulty in treating them with angioplasty or something. Our system was not geared up. So that has got better. We have understood how to tackle COVID patient with a heart attack. We have put in protocols, but it was a very rough and a tough time. We are learning, but still far, far, far away from the truth. We still have a lot of patients of COVID. We still have patients, non-COVID problems, and we are trying to balance out how do we manage.
Okay. Dr. Ganesh, if you could add on to it, like what was your experience and how prepared were you? Like initially when the pandemic arrived, no one would be like prepared. But the protocols you did you have protocols for doctors, frontline health workers? How streamlined this has become now?
Um, I mean, I think Dr. Cherian and Dr. Dalbir Singh have told what the problem is, and all of us, I think, have a similar kind of a problem where in the initial days, patients during the lockdown, patients were not coming, and they had their own problems in their home. Many were dying at home. That was one issue from the patient perspective. That has changed over a period of time. That now I think they are deciding that in spite of COVID, they have to go and get treated. The other perspective is the healthcare perspective, where the healthcare professionals uh, were not sure how to take care of themselves because we knew so little of the disease in February, March, April that one day there used to be news saying that it spreads by aerosol. Next day they used to say it spreads by fomites like handles and lift buttons and all those things. So nobody really knew what was happening and how to even protect ourselves. So there was a lot of scare, especially among surgeons, that you don't want to operate a COVID positive patient and then spread it to your team, and then everybody is in a problem. So we took whatever. At least during the lockdown, there were not many patients to even talk about. We used to do maybe one surgery a month or two surgeries a month, maybe six a month, and we used to take all precautions. But operating with the PPE is just as Dr. Cherian said, is an impossibility. I mean, any surgeon will vouch for it. Say you can't wear a PPE, wear loops, and then operate for 3-4 hours. It's just not possible. So you have to just choose our cases. Currently, what we are doing is we are testing them for COVID with RT-PCR, and if they are negative, we admit them and take moderate precautions, not PPE, but as respirators to N95 masks, and go ahead with surgery. Things are getting better, people are coming out, but I think the risk of health personnel contracting COVID is far more real today than it was 3 months ago. I don't know if the other panelists agree with that.
Okay, yeah. Dr. O.P. Yadava, coming back to you, if you could tell us, how it was the past 6 months, the experience, during the first lockdown when the pandemic hit immediately, and being an CEO of the National Heart Institute, you'd be leading a lot of patients coming in and coming out. So, what kind of infrastructure changes also had been done in hospital? If you could just highlight, Dr. O.P. You have to unmute, Dr. O.P.
Uh, yes, thanks a lot. A lot of things have been already said, and I endorsed most of them. It was a double whammy. Both the patients as well as the medical fraternity, we weren't prepared. So both sides, and then on top of it, fear complex, lack of information, and misinformation more than the lack of information. In fact, lack of information would have been a great thing. We would have been neutral. But having a wrong information was the most important thing. And as Balbir pointed out, the mortality has come down. But I think the most important thing which has happened with mortality coming down is a change in our concept of the pathogenesis of the disease. See, earlier we took it as an acute respiratory distress syndrome, the ARDS of the high altitude pulmonary edema type. And we were going in for early ventilation, high pressure ventilation, full ventilation, and that's what caused huge amount of damage. In fact, there is a study from Italy which came out when they looked at patients with no ventilation, oblique ventilation, and they found that the mortality was high on the patients, obviously, who were, in the ventilatory era versus the non-ventilatory era. So today we know it is a thrombotic process, and introduction of anticoagulants has changed a lot of it. As far as the infrastructure, the first thing was more than the infrastructure, it was to build that confidence level in the staff itself, which was very important. People were living, in drones, especially nurses from Northeast, because the hospitals in Northeast India, the government hospital, they opened up their recruitment portals. So all nurses working in a private sector in Delhi earning half the pay than what they will earn in a government setup back again at home, they all rushed back. So that was a big thing. How do we retain the human resources? And then training the human resources, giving PPE kit was not just sufficient. How to use the PPE kit. And the positivity rate in the staff was extremely high in the initial 6 weeks or so. Infrastructure, we learned that collapsing walls, that term which has been used, is what we follow. We closed down the areas where we didn't have the patients totally, and just created two areas, a COVID area and a non-COVID area, and tried to concentrate patients into these two areas, and acute care and chronic care were brought to some extent together to save the hospital resources. So those are the kind of changes as an administrator we had to do, and probably all hospitals had to do.
Okay. So coming on to the next question, I would like to ask Dr. Dalveer first. We are seeing a lot of research papers. Kindly ask the other speakers to go mute. Yeah, there's a research paper from a treatment center in Wuhan, China, which has shown that those with CVD are at risk, and cardiac injury can occur for those with confirmed COVID-19 if they don't have even the previous cardiovascular diseases also. This research paper is saying they might get CVD disease if they are getting admitted during this process. Can you just tell us, explain, is this true, or these kind of lot of research papers are there in circulating? How much one should believe this or not believe this? If you can tell, Dr. Dalvi.
So there are two things on this. Thing number one is that if a patient has a heart disease and now develops COVID, he is a higher risk of death, um, uh, going on ventilator, clearly higher risk. There is no doubt about it. They also have other comorbidities like hypertension, diabetes, which add on fuel to the fire in a coronary artery patient who's already got a stent or a bypass surgery and now develops COVID. So that's a bad news for any heart patients to develop. The second important thing is to know whether COVID can cause a heart disease. Yes, it can. It is not as common because at Max we treated huge amount of cardiac patients with COVID, and to develop a new illness with COVID from the heart point of view is possible, but not so common. So how do they develop a new heart disease? One is that it is a thrombotic state. Now, since as we evolved and learned about COVID, we also evolved and learned that heparin or blood thinning agents are very useful, and we give it to everybody. So one of the things that was happening was clot formation in the artery vessels, and this was leading to heart attacks. So this was one way they were getting affected. The second way was in depression of heart pumping, which is cardiomyopathy. Now there are various ways that a cardiomyopathy or low ejection fraction of the heart could develop in these patients, and one of the ways was a stress-induced cardiomyopathy in this patient. Third was development of myocarditis or the virus directly leading to some abnormalities in the heart. So there were multiple mechanisms on which this COVID illness could affect the heart. But predominantly, we understood very clearly that the major effect of this illness is on the lungs and forming clots. So we were on the watch to prevent clots and to prevent a lung disease. And we understand it better than what we understood in March or April. This is clear, March or April, even in May. It's clear that the understanding is better. Of course, as Professor Cherian clearly pointed out, that is something new. You don't learn about a disease in 3 months or 4 months. It is completely come out of a blue and hit us all hard.
Okay. Thanks, Dr. T.S. Clare, Chairman, PSRI Healthcare, PSI Heart Institute has joined us. Thanks a lot for joining in, sir. We had the discussion going on from 6. I would like to ask you this thing which I just asked Dr. Dalbir Singh ji. So there's a lot of research which is going on in terms with COVID-19 and cardiovascular disease. And there is a research paper where the treatment center in Wuhan, China, has shown that, although those with CVD are at risk, people who have cardiovascular disease, they are at risk. But when the people who are not having cardiovascular disease also, when they get admitted for COVID-19, they also develop such risks. So can you just give me your pointers? Is this correct? Is this can patients develop so? And if you can just add on your views to it.
Pratibha, first of all, I must thank you for inviting me to this rather wonderful, very important webinar. And I also would like to say hello to Professor Cherian and Balbir and Yadav, all my friends here. Now coming to the question of COVID and heart, it has two-way relationship, as a few points have been already enumerated by Dr. Balbir. His name is spelled wrong here. Actually, he is Balbir, not Dalbir. One is that if a patient has a cardiac disease, already he is more prone to get infection. That's number one. Number two, his chances of complication and mortality are high. But let me clarify this. Heart disease is not uniformity. Every patient heart disease doesn't have the same risk. We are talking about who got a very significant cardiac problem. For example, if a patient has heart failure, if a patient has a low ejection fraction, if a patient had devices like CRT and devices like ICD, if a patient had an angioplasty, his heart function is normal, his blood pressure is controlled, he is not at a really high risk to develop COVID and complications from the COVID. So there has to be a differentiation. But certainly comorbidities like any of these significant cardiac disease, like even the respiratory disease, obstructive wave disease, diabetes, elderly people, anybody who's got immunosuppressed, like post-transplant people, because they are immunosuppressant drugs, anybody who's taking steroids, because they lower the immunity of the individual. So they are all high risk group and they get more complications. Now coming to the other side of the story, if a patient is young, even like 25 or 20, 30, he can develop cardiac manifestation. And it has been seen that almost 15 to 20% patients of COVID, they have cardiac manifestation. Out of those, predominant one is heart attack. So when we say heart attack, it is again of two types. One is the true heart attack. True heart attack is when an artery of blood vessel, like a coronary artery, suddenly occludes 100%. If you have a 80 or 70% blockage, because COVID increases the coagulability of the blood, there is a more chance of clot formation. So over that blockage, you will have a clot and the artery will occlude suddenly. That will lead to heart attack. That is a true heart attack. And when you take these patients for angiography, you will find that the culprit artery is totally blocked and we need to open that artery. The second thing which happens is that the people will come with chest pain. They will come with STT changes, ECG changes, just like myocardial infarction or heart attack. But do their angiography, the coronaries are normal or no significant disease. No, what is that? That is a pseudo heart attack. These changes are because of the myocarditis, the effect of virus on the heart muscle, which is also called a myocarditis. That will be told. So this is one. The second thing is these patients are more prone to get arrhythmia. So you can have various kinds of arrhythmias like tachycardia, heart rate is more, or they can develop irregular heartbeat like atrial fibrillation. And the most important thing is that which has been seen in some patients, the patient is recovering. We are all happy that patient is recovering and patient is going home. And suddenly they had a cardiac arrest and they die. So there is a more chance of development of malignant ventricular arrhythmia like ventricular fibrillation, in these patients. So if a patient has recovered from a full attack of COVID, I would think that first 2 weeks one should be careful that they don't exert physically, they don't do anything which is out of the regime advised by the doctors, because these patients can get arrhythmias. So the third is that many of these patients, they present with low pumping capacity of the heart. That means low ejection fraction. Again, it is because of the inflammatory process in the heart muscle caused by myocarditis by the virus. And these patients present with heart failure. They will come with breathlessness and cough on lying down. It's a typical story of acute heart failure. So these are
Okay.
the main manifestations of COVID on the heart.
Okay. Dr. Cherin, your thoughts on this same, sir? Like how difficult it is, like, if there is a patient who doesn't have a CVD risk, but when he comes to COVID, with COVID-19, does he develop CVD risks? Is there any chances to it? And if you could also touch upon the usage of drugs, like the anticoagulants, which are like, does it help in improvement in in hospital survival in patients infected with COVID-19? Like, if you can just give us kind of uh, comment on that.
As I mentioned earlier at the beginning itself, I don't have any experience with treating COVID patients because basically I'm a cardiac surgeon. I don't do that work. But it is a question of indication for operation. When will you operate? How will you look after your team? And how to look after the post-operative. Now, those we have already dealt with. Now, regarding anticoagulants, this micropulmonary thromboembolism was detected in Bergamo, and that is after more than 50 patients died. One patient had post-mortem, and there they found out that it was due to micropulmonary embolism. From that time only, people started anticoagulation. Also, it was found that those patients who have been on aspirin, ecospirin, the chances were little less. Now, if you look into surgery, again you can see that the thromboembolic phenomena has been little different. If you put a patient on ECMO, the need for anticoagulation that is necessary, that is also less. So it is all controversy. That is why I am saying, this is a new disease. We have not made any protocol. And the protocol, from my experience, that is my own wife's, from what I have seen, is that do not ventilate these patients like any other patient who do not have, who might be having respiratory distress syndrome. But these patients who have got long-standing asthma, that's a different question. And you have to be very, very anticipatory, where if you go on increasing the peak, positive pressure ventilation, you can get pneumothorax. Patients could die from that. Now, regarding steroids, maximum dose given is 1 to 2 milligram per kilogram body weight. Now, that is not my field. Anyway, I will not talk anything about that. This is what I see. And we are not a
Okay.
whole hospital at all. We don't admit anybody, we just close it. So I can't talk about that also. But operating with all this stuff with you, and that is a very, very difficult proposition. I have not done it. From what I have seen, few cases, my colleagues who have done it, they say it is terrible. They want to get out of the workplace. Now, post-operative infection, that is the other side. Now, what happens to the cardiopulmonary bypass setup? All these are a different, you know, cup of tea.
Okay.
Surgical, surgical side,
Yeah.
there is nothing much for me to add except that the SOPs have to be made sure that, as I said, if you have got four theaters, keep the three theaters closed. Use only one. Then what happens to the team? How often you are going to change the team? That also comes. So, this is a new process. Now, you might even ask, what about vaccination? Everybody was expecting vaccination to come on 15th of August in the Independence Day. We know that it never happens. Phase 1, phase 2, phase 3 it has to go through. Now we also know that DNA, and it is not RNA, it is mRNA. And what is going to be the effect of mRNA on the whole body system? What are the complications? So these are all these physicians who are sitting around, they will discuss. For me, there is nothing to discuss.
Going back to OP Yadava ji, sir, if you can just give your thoughts on this, how when patients come in without a CVD risk, but I mean, for you, National Art Institute, mostly they will come in, but do you how do you see the pattern? Like, do they get this risk of CVD once they enter? And also, if you can talk about the anticoagulants which are associated with the improvements in.
Hear you.
Can you hear me now, sir? Can you hear me now?
No, it's getting streamed. The mangled sound I'm getting. I'm not getting clear
Okay,
sound.
Dr. Ganesh,
I couldn't get
can
your
I
question,
repeat the
please.
question? Can you hear me now? Yeah, I was
Yeah,
asking you, like, how do you see when the CVD risks, National Heart Institute will get only more majorly the cardiac patients only. But besides that, do you think when the people admitted with COVID-19 develop these risks, new risks of, CVD when they get admitted? How do you see this, pattern? Is this, correct? Does this happen? From your experience in the past 6 months, have you seen such cases? And also on the anticoagulants which are used and the drugs which are used, how does it improve? Like, do we have correct, information about the drugs which have been used and the devices which have been used? If you can throw some light on that.
sure. Now, first, by government regulations, we are all medium and large hospitals, more than 100 bed, are required to take COVID patients 20%. So we are treating even general COVID, not only cardiac COVID. Uh, Coming to that, yes, this COVID has affected the heart. We heard the direct effects of COVID on the heart, but more than what the virus does to the heart is what the body does to the heart itself. See, whenever the virus infects the body mounts an inflammatory response to limit the viral spread and to counteract the virus. And that inflammatory response till a particular point is protective and beneficial to the body, but go on beyond a particular point, it becomes harmful. And today, a lot of damage to the heart and the rest of the body is occurring because of the exaggerated immunologic directed inflammatory response that a human body mounts. Also, there is activation of these special constituents called macrophages, which, they dissolve the collagen plaque and helps it rupture. So a hard plaque becomes a soft plaque, it ruptures and produces a full-blown heart attack. So there are lots of mechanisms. And the third thing that I want to impress on is it's not just the acute damage, it is also the ongoing damage which occurs. Dr. Claire referred to, athletes for 2 weeks. We just had a study of 26 competitive athletes at school level coming from USA, out of which 4 had, MRI-based changes in the heart, and obviously they were banned for competitive sports. So the changes are not just acute changes. The changes are going to be seen maybe 6 months later, 1 year later, and we can just predict whether the heart failure incidence then will go up or what will happen. Your last thing about anticoagulants, it's now a given thing that the anticoagulants have to be used. In fact, just day before yesterday, and this is the first randomized controlled trial. Till now, all data we have been getting is an observational data, but this is the first randomized controlled trial of just 20 patients, which has come up from Michigan, where they looked at full dose anticoagulation versus prophylactic anticoagulation, and there is overwhelming support for full dose anticoagulation. It is not prophylactic anticoagulation. And we must also realize that the newer oral anticoagulant agents are not recommended during the intra-hospital phase. It has to be low molecular weight heparin used in full dose along with high dose of aspirin. So that level of anticoagulation. And once the patient is discharged from the hospital, then the debate can be on what level of anticoagulation and for how long, but it is recommended probably for minimum 6 to 8 weeks thereafter also. So anticoagulation is one of the most important things which has changed the prognosis of this disease.
Okay. Yeah. Moving on to Dr. Yeah.
Pratibha,
Claire, you-
Pratibha, can I interfere?
Yeah, yeah.
Dr.
Yeah,
Yadav,
yes.
can you please elaborate? The COVID patients are various grades. There are patients who have no symptoms at all. There are patients with mild symptoms. So what are those patients where you would like to use anticoagulation? Not in everybody. Am I right?
Sir, I thought the question was asked for what you do at National Heart Institute. So we are talking of hospitalized patient.
Okay.
Hospitalized patient, the answer is 100% of patients. Hospitalized patient we are using for everyone, whether we're using right or wrong, but at least we use it for everyone.
Thanks a lot for that question and the answer in between. Dr. Ganesh, quickly, your viewpoints on the same. If you could just add on to it, and so we can move on. Yeah.
Well, there is not much that I would like to add on except saying that I don't treat COVID patients myself. I'm primarily a surgeon. My only involvement with COVID patients is when they call me to put ECMO on these patients. We have done a few of them. And I would just like to tell the panel and rest of the people who are listening to this one interesting case. A young fellow came with ventricular fibrillation, resuscitated, the heart came back, and the family wanted whatever possible done. I'm talking this in terms of the coagulopathy that happens. We open cannulated the femoral vein and artery, and there was no blood flow. No blood flow. The entire femoral vein and the IVC was full of clot. We could not get any flow. So I'm just saying that we know so little about the disease that we are basing our treatment based on some paper here, some paper in Wuhan, some paper here, some paper there. But I would like to humbly submit as a physician that I think we know very little about the disease. We are doing whatever we think is right from whatever information we have, but I think the information we have is far too little to make any meaningful inferences at any level.
Okay. Now, coming back to technology being used, a lot of technology is, now being used after this pandemic and since the lockdown. The telecardiology is actually is increased, and telemedicine has increased manyfold, and also other innovative technologies have come in place. And I would like to ask Dr. Balbir Singh, who has recently done a Bluetooth pacemaker thing. He had placed this so that the patient can not come to hospital again and again. Visits of hospital is being like restrained. So Dr. Balbir Singh, can you just explain to us the advanced technology which has been done in Max, and how this can be taken forward? Such innovative technologies. I would like to ask the other panels also. First from you, like yeah.
So the COVID has taught us some new norms, new normals, which are going to last for a long time. One of the new norms is like we are sitting on online and chatting, and the world is watching this. Similarly, we had many medical conferences online, which never happened in the past. We never thought that this will happen. We were introduced to a telemedicine, which is somewhat in infancy. I would think we need some better tools to do it. So fortunately for us, on 29th February, we did a device which is an ICD with a Bluetooth. This was the fourth implant in the globe, and the first in Asia. And this implant, it was so simple for the family that they have not come for a follow-up since then, because they transmit all their reports from the ICD, which is like counts every heartbeat, every second, every minute, 24/7, and gives us a printed. We can take a printout of what is happening from the home. They just have to click on the mobile phone and collect the data and send it to us. Now we have done about 10 such cases since last 6 months. It is gratifying. So we will see a huge shift happening towards online conferences, people not traveling too much, and this is not going to stop. This is not going to stop even after the vaccine comes, or even if the corona cases come down. This fear is going to lag on for a long time, and we'll have a lot of improvement in the way the online things are done, way the patient's telemedicine is done. It is in infancy at the moment, and this device is one of the a clear indicator what we are heading for. We are heading for patients sitting at home, sending us data, and we interpret through our computers, our mind. So it is not to say that we are going to lose skills as a physician. We are going to get sharper. We are going to get better. We are going to learn much more different things than we ever did. And this is a very interesting field which is evolving now into this. Some clinics have gone to robotic surgeries done from off-site, robotic angioplasty being done from outside. So somebody is sitting somewhere else and guiding the robot to operate some kilometers away, which is also possible. So we are going to have a major shift in how medicine is going to be practiced in the future. And it's going to be a great contribution from IT and artificial intelligence, which is going to take a huge shape in the next decade that is to follow.
Okay, thanks a lot, Dr. Balbir. I would like to get insights from Dr. Ganesh Krishnan from Master. Dr. Ganesh, what kind of innovations you have seen in this, 6 months, or you have been doing in Aster? Aster is a big group, so you must be doing a lot of innovations when it comes for cardiac sciences in particular. Any kind of innovations you're looking out for, and particularly in cardiology and teleconsultations, how it has increased in many fold.
I was going to come to it. There are, technical innovations that one does. I think the greatest contributor in terms of innovation to cardiac surgery in the country is sitting right with us, Dr. K.M. Cherian. He has got hundreds, maybe. He has got a book this thick, only his publications.
I'll come to summarize this point. 2005 they have started. Yes, I know.
So he is one of the greatest contributors and innovators. He's they're designing bovine pericardium. So I would not go into those innovations. I think the innovations that we have come across is more out of necessity. If a patient needs to consult me, how do I talk to him safely? How do I get him, I should not get infected and he should not get infected. So I think the major innovation, or I would not say innovation, it has always been there. I think it's just a application of a technology, because video conferencing was always there, but we never used it to talk to patients, because we needed to auscultate them, we needed to check their blood pressure. But we have done away with those things and just say, oh, how are you feeling? Are you feeling all right? Do you have any complaints? and prescribe some drugs over the internet. So yeah, teleconsultations have gone up. Now on an average, about 50% of my patients would like to teleconsult, because they would not, because most of them are bypasses or elderly patients. They're afraid to come to the hospital. Now we have to adjust to that, and maybe it's just my feeling that maybe this will be the new norm, that many of them would want to consult with you on video or teleconsult, and then if necessary come for a physical visit. I don't know what Dr. Yadava thinks about this, but this is how I think it will move, and some of this teleconsultation will be there to stay. So I don't think I would call it an innovation of sorts, but necessity to continue with what we are doing and provide service, and opportunity for the patients to communicate with us and get their problem solved.
Okay. Dr. T.S. Clare, in PSRI, what kind of, I hope, yes, teleconsultations would be happening for sure, but other kind of, innovations in cardiac institute, which is happening the past 6 months, if you could just highlight those, please.
I think the COVID has really taught us so many lessons. One, it has shown us that such a small microscopic structure can bring the whole world on its knees. The COVID doesn't bother about prime ministers, home ministers of any country, including the president of the United States of America. And COVID has also shown one thing good, that it doesn't bother about rich and poor people. It is everybody's same. This number two is, it has also, at least to me, it has also realized that perhaps the health remains the most important aspect of life. I tell people three things important in life are health, health, and health, nothing else. Now coming to the telemedicine part, I think there is no doubt that Corona has made us realize, as Ganeshwar said, that the technology was already there, but it has made us realize that it is so useful and it is possible. Believe me that in cardiology, 80% of the patients can be totally seen, evaluated on telecardiology. They don't need to come. And only 15 to 20% of the patients will need to come to the hospital for physical examination and for investigation. Somebody needs an angiography, somebody needs a change of pacemaker, he has to come. But otherwise, most of the other things can be sorted out by telemedicine. And I believe we talked about the Bluetooth technology. In fact, that remote control devices for monitoring of devices have been there for many, many years, more than 2 decades, almost 1.5 decades. The only difference with this new technology has made is that it is available on Bluetooth technology on a cell phone. Previously, we used to give them an additional box the patient will keep in his room, and that will send the information to us. That's the only thing which has changed. So it has made the necessity to buy a special equipment has gone away. So that's a good improvement. But remote control of devices was already present. See, I can tell you one thing, that I had almost daily 1 or 2 consultations from Bangladesh. I have had a consultation from Chittagong, Cox's Bazar, Nepal, and Afghanistan. So you can imagine the utility of telemedicine, that people sitting in Kabul, they can have a consultation right in Delhi, and the problem can be sorted out at least in 80% of the patients. I think that is going to be norm actually in the future. In fact, to my mind, telemedicine has much more relevance to India. It's a huge country, and there are people sitting in Nagaland, there are people sitting in mountains, and if we have a technology, a lot of healthcare improvement can occur in our country. Actually, the future lies in the e-medicine, the e-health of individuals. If I attended last year the TCT meeting in California, and one guy from ID was telling the futuristic things to happen in medicine. There are going to be small injectable chip which can send all the information to the doctor about that patient. Even it can predict, hopefully, that if somebody is going to have heart attack tomorrow or day after. So a lot of new things are going to come in the telemedicine, and the e-health is becoming more and more important. The only thing which bothers my mind is that in this When a doctor touches the patient, he auscultates or he palpates his tummy. There is a personal touch. That personal touch is lacking. Apart from that, there doesn't seem to be any great disadvantage in telemedicine, because the on video you talk to the patient, you can perceive the emotions and everything else is noted, but the personal touch of a physician is something which is very useful for many patients. They feel very satisfied when a doctor auscultates them. But I think in future, more and more patients will understand that the stethoscope is not needed in most of the patients. There are some patients even now, like for example, they have hypertension. They will tell me, "Okay, sir, आपने स्टेथो लगा के नहीं देखी." They will tell me it was not needed, but patients do feel that personal touch is required in some of the situations. But I think we have come a long way, and in India, in fact, the government should make more rules and regulations for the spread of telemedicine, how reimbursement is going to happen, and what are the legal issues involved if a doctor advises on the telemedicine. So all those things need to be sorted out by the government in our country.
Okay, Mr. Clear. O.P. Yadav ji, if you can just talk about the teleconsultations happening in National Heart Institute and how multi-flow digits increased, and your thoughts on the innovations side also, if you could. Yeah.
See, most of the innovations we heard, actually, let me first talk of the semantics. Telemedicine itself looks a very constrictive term and restrictive term. Telehealth is the term that we are talking today because it's much wider than telemedicine. Now, what we were talking is what we call the third level of telehealth with remote sensing and remote monitoring. But more relevant to India today is what we call as asynchronous telehealth. And that asynchronous is when the opposite side person is uneducated, he doesn't have the gadget to communicate with you, and he has a lower than a doctor's qualified person, maybe a physician assistant, maybe just a technology enabled IT person who can collect the information and transmit to the doctor. And that's what we are practicing. We had an MOU with the official MOU with government of Uttarakhand, and in Almora in the Kumaon Himalayas in the base hospital, there's a cardiac center. And we have gone up to the village called Supi, which is the second last village on the Indian side before the Chinese border. And we were able to collect the asynchronous data. The local nurse there, not a nurse, a lady who was brought to National Heart for just 3 weeks, taught these things, sent back. She goes to these villages carrying that small little gadget with her, and she records and transmits to us, and we transmit the information back, and then she goes and shows it to the people if synchronous telecommunication is not possible. Synchronous is when we have live one-to-one chat. She's assisting, but it's live one-to-one chat. But sometimes the systems, the broadband doesn't work, the telecommunication in these remote areas may not be good. Then the asynchronous ones comes in. So I think the country, needs these kind of innovations, and that is going to take forwards, because what we were discussing is all very limited number of people in the urban areas. I think telemedicine is important to urban. I'm not denying everything what's been said is important, but equally we need to take it to the underprivileged in the backyards of the country.
Thanks a lot, Dr. O.P. Yadav. I'm coming to Dr. Kane Cherian, who has introduced in 2005 in Frontier Lifeline Hospital telecardiology, if I'm not wrong, Dr. Cherian. If you can just tell us, how it has been there. Yes, as other panelists also spotted, it has been there, teleconsultations has been there, but this pandemic has given much more importance to it. So if you can just highlight how this can be taken forward, this teleconsultations and this lot of other innovations which are coming in, how should we take it forward? Dr. Cherin, you're on mute.
Yeah, he has to unmute himself.
I said we started the telemedicine in our unit in 2005 mainly because We have another unit in a very small village in Kerala with a population of 7,300. And nobody thought that, that unit will pick up so much, mainly because of telemedicine first. And it may be of interest for everybody to know that we were the first one to use the satellite, exclusive satellite, when Dr. Abdul Kalam was the president. The third thing I would like to say is that we talk about robotic surgery, transatlantic robotic surgery. But to me, it is meaningless. The reason is this: I became a surgeon mainly because of the tactile sensation. I get thrill out of that only. If a robot does it, why the hell I should be a surgeon? I must be using the joystick. I'm being frank about it. Definitely, it will help remote places. We have connectivity with Kerala. We have connectivity with Uganda. We have got connectivity with Tanganyika. Now, leave alone all those things. Let us come to innovation. We have, we had, our the biggest university, Nalanda, 560 BC. What is the state of Nalanda today? Nalanda had 10,000 students and had 1,000 professors. Can you talk about Nalanda today? No. In fact, DST people, they asked me to do a workshop for them last October. I got Shiba International, Harvard, and UTW to take part, including CRIB, that is the Korean Research Institute. We did the whole thing on, by virtual reality on a cloud platform. Now you know that it has come to augmented, reality. We have got 7,500 cardiac specimens. We are digitizing that so that you can pick up sitting in Delhi or sitting in Assam or China or wherever it is. Now these specimens are available. That is again because of the technology. I'll tell you something more. If you are talking about money, 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 forget it. 2030 is going to be the era of bioeconomy. So get prepared for that. I won't be there, but be prepared for that. So talk about bioeconomy, talk about cloud platform, talk about virtual reality and augmented reality. You can have all these things. Telemedicine will be very easy. You can have, give a lecture in Japanese, even if you don't know anything about Japanese, in there, in Tokyo or Osaka or somewhere. So all these are going to happen. Now, when I did this for Department of Science and Technology, at their request, after the meeting is over, 2-day workshop is over, I did not even get a letter saying that, yes, you did a good job or thanks for helping us. I was only trying to help that this science is possible in India also. Unfortunately, DST or TDB or CDSEO or you name all the organizations, I don't care about who listens to this. The support is zero. Absolutely zero. You people might get. Unfortunately, I am sitting in the south. Nobody even sees me. But I just want to tell you, all these are possible. and make it possible that bioeconomy will be a success, a huge success for India. That's all I have to say.
Thanks a lot, sir. I want to again ask Dr. Kane Cherin to give. We are almost done with that. The closing in the closing remarks. I would like to ask you, what do you want to? What are the lessons we have learned, like from this pandemic, and what should the government do going ahead? What kind of things, the infectious diseases, the government should come up with an SOP, a guideline, a protocol for frontline health workers, for cardiac, sciences. Can you just tell us a few pointers which the state government and the central government should do?
Are you asking me? Hello.
Yes, yes,
Yes,
Cherian
yes,
sir.
yes,
If
yes.
you ask,
If you are asking me, I'll tell you one thing. To be very frank, don't take it otherwise. I have filed a PAL against the government of India.
I know that, sir.
13 cases have been filed. None of these people will do it. But because I am not waiting for a pension, I'm not waiting for gratuity. I don't live on this. And government of India, after having me left my resident status in US in 1969, came back to this country, worked for 1071 rupees. Nobody will do it. Resident status in two countries were left. I don't regret because you have called me here today. Otherwise, I would not have been called. I can say that I did the first bypass or a lung transplant or a heart and lung transplant at December. That has been possible only because I am in India. Otherwise, I would not have been able to do it. So, as far as I am concerned, as I said, we have to progress, think, look for 2030, which is going to be bioeconomy, because everybody talks only on money.
Okay, thanks a lot, Dr. Cherry. Dr. T.S. Clare, your thoughts? What kind of, आगे जाके, what kind of SOPs and protocols and guidelines should be made for infectious diseases, particularly in cardiac science? Should we have some? And what kind of, things should come in place, and how soon should it come? From the state government point of view, also from the central government also. Your thoughts on it?
yeah, see, first of all, I would like to share a case with my colleagues, Dr. Cherian, Dr. Yadav, which happened recently in at Gurgaon hospital. This patient came with the COVID and he had a clot in the right ventricle, and this clot went into the lungs that causes pulmonary embolism. This patient was taken for angiography, which showed also blockage in the coronary arteries. So the surgeon in the middle of the night did they removed the clot from the right ventricle, removed the clot from the pulmonary artery, and they did also bypass surgery. This may be the first case of this kind in the whole world. The patient is recovering, but we don't know as yet whether he will make it or not. But I thought I should share with Dr. Chirian and Dr. Yadav such a unique case. Now, coming to the question of SOPs and policies, I think it should come from the Ministry of Health. It is not something which should be at the state level. The government of India should make rules and regulations on a country basis. The whole all over India, the SOPs for telemedicine and the in fact it's not only telemedicine, as Yadav said very correctly. We should now use the term health rather than just say telemedicine. There are a lot of things which will come in the future, and I am very definite that the e-health is going to make the life of an average Indian sitting in a far off place will make it easy, so that one thing, this e-health opportunity is such that it can bring quality care, quality health even to remote places, which is not so far available in India. For example, in Delhi, Bombay, there are 5-star, 6-star hospitals But you go 50 kilometers or 60 kilometers out of Delhi, there's nothing available. Neither there are good doctors nor there are facilities. But at least the e-health promises at least a good diagnosis for those people even sitting in small places. But for that, we need to, first of all, our improvement in the quality of these e-health has to go much better. We have to have a very strong broadband or whatever, that's a technology which I don't know, very reliable distribution it has to be developed. Maybe we have to have some separate channels for e-health in India, so that it doesn't interfere with the transmission of other data of other departments. So I don't know how to do it, but certainly we need to bring in more legalization and more SOPs to develop e-health to a new level.
Thank you, Dr. Claire. Dr. Ganesh, if you can just tell us, what kind of guidelines and SOPs should be coming in the future in infectious diseases, if you could.
And look, I am not qualified to opine on what sort of guidelines should be coming or what. One thing I know for a fact is that there is a disconnect between the political system of the country and the ground reality. The politicians do what they want, which will get them votes, and the bureaucrats, they do what they want. And I think as why did Dr. Kim have to file a PIL? Because there is absolutely no support for innovation and doing the right thing for the patient. So, guideline कैसा होना चाहिए, I don't even want to talk about it. Because people who make the guidelines is some bureaucrat who's being advised by some people. I don't know whether they are even qualified to opine. So I don't want even to talk about it. So I think I'll keep quiet here.
See, one thing I just want to add here, Ganesh. I like your way of putting the things in a very, very sophisticated manner. But let me tell you one thing, that it's very difficult to be heard in this country. Whatever position you may have. I'm in Delhi. I have been at a Scots Heart Institute for 28 years, and I have treated so-called very big BBI persons, including the Prime Minister of India. Nobody listens in this country. I tell you, it's very difficult that we can put across these things. See, now 75% of the healthcare delivery in the country is private medicine. 25% is by the public sector. But even the new medical commission which has been formed, there is hardly participation of any senior people or people of caliber from private sector. So I don't know why this, and I have talked to the people who are responsible for making this, but nobody listens here. So that's the thing.
That's exactly what I'm trying to say.
Yeah.
80% is private healthcare. 80% of research is from private places. 80% of everything is private.
Yes.
But 100% control is by government and by
Right.
Babu, who don't understand anything.
Yes.
So, I don't know how things are going to improve. I mean, I'm
I
being
mean,
very honest about it.
yeah, yeah, it's
Reality.
quite interesting when it comes private and government, but we have a time limit. So, Dr. O.P. Yadav, please if you can just let us know your thoughts. Yeah, 1 second. Dr. Cherin, you have to make some point.
Mine is muted.
Dr. Cherin, you have something to say?
Yes.
Yeah, please.
Now, if you ask me to talk, I'll talk the whole day.
I know, sir, but that's what I'm saying. This is an interesting debate. If you can quickly make your point, and I want Dr. O.P. Yadav's viewpoint as well.
What is there to say? Like Ganesh said, who makes the rules and regulations? Now, when people ask me, I say that if you have been lucky to have a resident status, qualified, a job, please don't come back to the country. It's not worth. I'm telling you, after 44 years, people like me doing it, absolute out of stupidity. People call me mad. But somebody has to tell this. Somebody has to tell what is Niti Aayog. Now, what funds you get for research? What is the interest rate? The banks, they say it is 5.5% or NABARD rate, but the banks will not give you for less than 12.5. How
Okay,
you
sir.
do? I don't want to get into all these things.
Yeah, please. Let's keep
You
it to World Heart Day. So,
Yes,
Dr. O.P. Yadava, your final thoughts. Yeah, yeah, yeah,
as a last word, let me tell you one thing. You want to please
yeah.
everybody. Now, Dr. Clark said he had treated two, three prime ministers. If I were in that position, I would have told the prime minister, this is not the way to go. But who will listen?
Okay.
Yeah, I am nothing.
सर सर कोई नहीं सुनता, मैंने कह चुका हूँ, मैं
Yeah,
बोल
sir.
चुका हूँ सर
आप
कोई
लोग भी मेरा थोड़ा सुन लीजिए. Dr. O.P. Yadav, your please your final viewpoints on this, the guidelines.
Yeah, my final viewpoint is, if you have heard this name called Mary Lasker. See, when the cancer research was going on in 1930s and 1940s, early 50s, they were not making any headway. The industry was suppressing everything. It was Mary Lasker who was the frontline researcher, realizing that no one is listening to her. She gave up her research job totally and started rationing and doing advocacy. And it is her story that the most important thing in any research work is advocacy. So it's important that we as doctors, instead of gloating on the fact that we have not made any headway, we should be realizing our power and doing some advocacy, and then we will be able to march forward. As far as
Okay.
the, as far as the guidelines are concerned, my only request to the guideline making authorities is please make them relevant to the society that they cater for. Science cannot be can't be discordant to the society it's looking after. Now, recently we have guidelines regarding recycling. Now, recycling has been made so difficult that in cardiology, no catheters are being recycled now. Is that that's the interest of the country going to be met? So whatever guidelines are made, they should be relevant to the society. And I might like to differ with Dr. Clare. I think they will have to be made at regional levels because India is such a big country. Our cultural, religious, socio-economic situation changes every 100 kilometers, and every state will have to come out with its own protocols. Thank you.
Thanks a lot. Thanks a lot to all the panelists here who had joined us for the World Art Day and giving your time here. And we would just want to give you all, as our token of appreciation, a speaker certificate for you. I would like to ask my back-end people to just put it here. Thank you, Dr. K.M. Cherian, cardiac surgeon, Frontier Lifeline Hospital. Thanks a lot, sir. Your whatever insights you had was really good. Dr. Balveer Singh had to leave, so we will give the certificate to him. We'll send it to him. He had some OT. And next is Dr. T.S. Clare, Chairman, PSRI Heart Institute. Both, Dhanyavad, sir, you had come, you had joined.
thank you.
And Dr. Ganesh Krishnan Iyer from Astra CMI Hospital. Thanks a lot, sir, for joining in early and coming and giving your thoughts here. And our dear O.P. Yadava ji, who always picks up the call in one ring for me and always says yes for webinar sessions. Thanks a lot, Dr. O.P. Yadava. Thanks a lot for all the veteran panelists here. Meet you soon in next panel discussion, which we'll organize. Let's Technomedia keeps organizing. India keeps doing a lot of good work. Hope you'll associate yourself with us. Thanks a lot. Thank you.
Thank you. Bye bye. Thank you very much.